Hello everyone. Today, as you can see, we are going to discuss the tongue. As you know, the tongue is a muscular organ covered by mucous membrane, and it is situated partly within the oral cavity and partly within the oropharynx. In this picture you can see that the tongue is partly within the oral cavity, the oral part of the tongue, and this posterior 1/3. This is within the oropharynx. In this cross section or in the sagittal section of the head and neck, you can see that three parts of the pharynx. Behind the nose you have the nasopharynx, behind the oral cavity you have the oropharynx, and behind the larynx you have the laryngopharynx. So you can make out the tongue does have an anterior 2/3 which is the oral part, and a posterior 1/3 which is the pharyngeal part. So oral part of the tongue, pharyngeal part of the tongue, anterior 2/3 of the tongue, posterior 1/3 of the tongue. And this tongue, which has got multiple functions, it is important for speech, it is important for taste, it is important for mastication, it is important as a very essential tactile organ, because the tongue, you know, is a very sensitive organ also, and it is important for swallowing or deglutition. Now if you open the mouth, this is the picture that you can see, and here in the relaxed open mouth you can see the tongue. This is the dorsum of the tongue. You can see the tip of the tongue. You can see the lateral margins of the tongue. But in the normal position, you can only see the oral part of the tongue. That is the anterior 2/3 of the tongue. And again, you can make out the tip, the dorsal surface or the dorsum, and the lateral margins. Now, when you lift the tongue and you look at it from below, you also have a ventral surface of the tongue. This is the ventral surface of the tongue. So dorsal surface, ventral surface, tip, lateral margins, and the attached part of the tongue, which extends from the mandible to the hyoid bone, is the root of the tongue. Over here you have the attached part of the tongue, which is the root of the tongue, and the remaining part is the free surface of the tongue. So you have also a root of the tongue, free part of the tongue, tip of the tongue, lateral margins of the tongue, dorsum or dorsal surface of the tongue, and ventral surface of the tongue. So you can see that the tongue is actually anchored anteroinferiorly from the mandible to the hyoid, and the rest of the tongue is free. So if this bulk of the tongue were to relax totally, the tongue would drop back and choke the laryngopharynx and the oropharynx as well. So it is good that all the muscles of the tongue are actually pulling it anteriorly, and only one muscle is pulling it posteriorly, so that the net effect of muscle contraction of the tongue is to bring it forward and downward towards the root, that is towards the floor of the mouth, from the mandible to the hyoid bone. Again, if we come back to this picture, in the relaxed open mouth view, you can see the dorsum of the tongue, and here you can see the soft palate. Here is the roof of the oral cavity, and here you can see the soft palate. A little bit anterior to the soft palate would have been the hard palate, but you can make out the uvula, and on the sides over here you can make out the palatoglossal arches. That is the uvula, palatoglossal arches, dorsum of the tongue, and the sides, lateral margins of the tongue. And this is the oral part of the tongue, the anterior 2/3 of the tongue. So this is the amount of soft tissue that should be visualized in an ordinary individual in the open mouth view. Now this is also the basis of anesthetic assessment for ease of tracheal intubation. The more you can see of the soft tissues over here, the easier it will be to insert a laryngoscope blade and take a look at the laryngeal opening and to intubate the patient. And the less that you can see of this soft tissue mass, the more difficult it will be for the anesthetist to intubate the patient. Therefore, this open mouth view of the interior of the oral cavity is very important. Now suppose you tell this person to protrude the tongue and say ah, like you do when you are examining a patient. So when the person does ah and protrudes the tongue to the maximum, then beyond the oral part of the tongue you can also see a little bit of the pharyngeal part of the tongue. So now you have anterior 2/3 of the tongue as well as posterior 1/3 of the tongue. And you can see there is a difference in texture and a difference in nature between the anterior 2/3 and the posterior 1/3 of the tongue. On the anterior 2/3 of the tongue, you can make out this surface is roughened by the presence of multiple papillae, and the posterior 1/3 of the tongue is rather smooth. and rather smooth. Although it is rather smooth and glistening, it does have ups and downs. It has a lumpy, bumpy appearance because underneath the mucosa of the posterior 1/3 of the tongue you have considerable amounts of lymphoid tissue forming what we call the lingual tonsil. So the posterior 1/3 of the tongue, though the surface is smooth, it is bumpy and slightly uneven because of the underlying lymphoid tissue, and the mucosa in the posterior 1/3 of the tongue is slightly loosely attached to the underlying tissues and the muscles, and in the anterior 2/3 of the tongue the mucosa is firmly attached to the underlying subcutaneous submucous tissue and the muscles. And as we have said, you have a median furrow in the tongue, and you have the irregularities on the surface, the grittiness on the surface because of the presence of the different papilla. Now at the junctional point between the anterior 2/3 and the posterior 1/3 of the tongue, you have this V-shaped, this sulcus, V-shaped sulcus terminalis, which differentiates the anterior 2/3 and posterior 1/3 of the tongue, and at the apex of the V there is a small depression which is the position of the foramen cecum. This is the beginning, this point marks the beginning of the thyroglossal duct, from which a pipe, the thyroglossal duct, will descend down through the soft tissues of the neck in the midline, and which will give rise to the median part of the thyroid gland. So the foramen cecum is a remnant of the beginning of the thyroglossal duct, so much so that occasionally you can have remnants of thyroid tissue underneath this point. Even within the substance of the lung, the substance of the tongue, you can have a lingual thyroid. So again, anterior 2/3 of the tongue, posterior 1/3 of the tongue, anterior 2/3 made rough by the papillae, posterior 1/3 made uneven by the underlying lymphoid tissue. Now just in front of the sulcus terminalis you can make out some very large papillae, about 8 to 12 papillae, which are again arranged in a V-shaped manner, and these exceptionally large papillae are the circumvallate papillae. This vallum means a ditch, so circumvallate means around the papillae you have a ditch, a small sort of ditch, circular ditch, from which the broad circumvallate papillae will arise, and this is the largest set of the papillae. Apart from that, you have the fungiform papillae like this, mushroom shape, which has a bulbous tip and a stalk, and you have filiform papillae, which are just pointed and regular elevations from the surface of the epithelium. So from the surface epithelium you have papillae, you have the filiform papillae, you have the fungiform papillae, you have the circumvallate papillae, and at the lateral margins of the tongue, close to the sulcus terminalis, you have the vertically arranged foliate papillae, leaf-like. These are slit-like on the lateral margins of the tongue and towards the junction of the anterior 2/3 and the posterior 1/3. Now these filiform papillae don't bear taste buds, but all the other papillae, that is the fungiform, circumvallate and foliate papillae, they bear taste buds. So you can see these small taste buds over here. And not only does these papillae contain the taste buds, the base of these papillae have certain seromucous glands, which is much more prominent in the vellum or the ditch of the circumvallate papillae. For the circumvallate papillae, these glands are quite prominent and they are called von Ebner's glands, and the secretions of these glands actually wash out the taste elements or the juices from the food that the tongue is sampling and allow fresh food material to come in contact with the taste buds. Now if you look at these individual taste buds, these taste buds have an onion peel appearance, and you have the gustatory cells and the supporting cells, and you have towards the tip you have a taste pore or a gustatory pore in which you have multiple hairs bearing the taste receptors. So the gustatory cells, sustentacular cell, taste hairs and taste pore, and these gustatory cells receive are the beginning of the afferent nerve fibers for subserving the function of taste. So they are richly supplied with nerves. These taste buds are richly supplied with nerves, and they extend over the tongue, soft palate, over the epiglottis, and partially over the pharyngeal wall as well. Now if you look at the surface of the tongue is lined by a stratified squamous epithelium. Stratified squamous epithelium means it is multi-layered, and as far as keratinization is concerned, the tips of these filiform papillae, they are keratinized. So the tips of the filiform papillae are keratinized, and some patches of this stratified squamous epithelium may also bear mild keratinization, but the tips of these filiform papillae are well keratinized, and these filiform papillae actually help in gripping the food and other substances. So gripping of the food materials is mainly due to these filiform papillae. And if you look at the dermo-epidermal junction over here, the dermal papillae also are quite prominent and extend as prominent papillae within the epidermis. So these dermal papillae are also called the papillae simplicis. So you have different kind of papillae. You have the filiform papillae, fungiform papillae, circumvallate papillae, foliate papillae, and the papillae simplicis, and you have the taste buds. So again we come back to this picture. When the person is saying ah and protruding the tongue, you can see the oral part of the tongue, you can see the pharyngeal part of the tongue, you can see the sulcus terminalis, you can see the foramen cecum, and at the junction of the oral and pharyngeal parts of the tongue, from the side walls of the oropharynx, you can see the fold of the palatoglossal arch. So on the side walls of the posterior 1/3 of the tongue, anteriorly you have the palatoglossal arch, posteriorly you have the palatopharyngeal arch. This is going down into the pharynx. So palatoglossal arch, palatopharyngeal arch on the sides, and this triangular gap between the palatoglossal and the palatopharyngeal arches is the tonsillar fossa, which contains, as you can see here, the palatine tonsil. So in the posterior 1/3 of the tongue you have the lingual tonsil, on the sides over here you have the palatine tonsil, and again somewhere here where the auditory tubes are opening up behind, you have the tubal tonsil, and on the posterior pharyngeal wall high up you have the nasopharyngeal tonsil, what we call the adenoids. So the lingual tonsil, palatine tonsil, tubal tonsil, and nasopharyngeal tonsil, they are guarding the walls of the pharynx, and this entire ring of lymphoid tissue obliquely situated from the posterior pharyngeal wall right up to the posterior 1/3 of the tongue, this is called Waldeyer's ring. But we will study that again when we study the pharynx. So this is not a class on the pharynx. Let's stick to our business. So behind the posterior 1/3 of the tongue, this elevation that you can see is that of the epiglottis. So behind the posterior 1/3 of the tongue, over here you can see the epiglottis, and you can make out that the mucous membrane of the tongue is reflected to the posterior wall of the epiglottis, and then the tip of the epiglottis, then the anterior wall of the epiglottis. So behind the tongue, between the posterior 1/3 of the tongue and the epiglottis, there is a depression over here. So somewhere here there is a depression, and in this depression you have a fold of mucous membrane that is called the medial glossoepiglottic fold. So from the posterior 1/3 of the tongue to the epiglottis, you have the medial glossoepiglottic fold. From the posterior 1/3 of the tongue to the epiglottis, you have the medial glossoepiglottic fold. And you know that when you make a big ah and you open your mouth and you look inside with a torch, particularly if you use a tongue depressor to depress the tongue, you can very well see the tip of the epiglottis and the medial glossoepiglottic fold, and from the sides you can make out the lateral glossoepiglottic fold. Now the lateral glossoepiglottic folds are not actually going between the tongue and the epiglottis, they are going from the epiglottis to the pharynx. So the lateral glossoepiglottic fold is truly the pharyngoepiglottic fold, and between this median glossoepiglottic fold and this lateral glossoepiglottic, or actually the pharyngoepiglottic fold, you have two depressions. This is called the vallecula. So you have the vallecula, posterior 1/3 of the tongue, epiglottis, median glossoepiglottic fold, lateral glossoepiglottic fold, palatoglossal arch, palatopharyngeal arch, tonsillar fossa, palatine tonsil. So many things you can make out from this picture. So from this picture we have studied the mucous membrane coating the tongue, the stratified squamous epithelium, the filiform papilla, the fungiform papilla, the circumvallate papilla, the foliate papilla, the dermoepidermal junctional papilla or the papilla simplicis, and the taste buds with the gustatory cells, supporting cells, taste pores, and the filaments within. And now if we ask the patient to lift the tongue, what are you going to see on the under surface? If you lift the tongue in the midline on the under surface, so this is the under surface of the tongue and this is the floor of the mouth, and here is the junction between the under surface of the tongue and the floor of the mouth. So on the under surface of the tongue in the midline you have the frenulum. So this is the frenulum of the tongue, and you know that if this frenulum is short and contracted, you cannot raise the tongue properly, and this is a condition which is called tongue tie. So a short frenulum, a contracted frenulum causes difficulty in elevating the tongue, leading to tongue tie. And by the sides of the tongue or sides of the frenulum over here, you can see the deep lingual veins. These blue structures, these are the deep lingual veins, and by the sides of it you can see a mucous fold that is called the plica fimbriata. So it's a fold which is fimbriated or wavy or undulating. So you have an undulating fold over here. So frenulum of the tongue, deep lingual vein, plica fimbriata. These are the things that you will see on the under surface of the tongue. And when you come to the junction of the tongue and the floor of the oral cavity, you can make out the sublingual papilla over here. One sublingual papilla here, one sublingual papilla here, and on the summit of the sublingual papilla you have the opening of the submandibular salivary gland. So sublingual papilla on the summit, opening of the submandibular salivary gland, and then you have a sublingual elevation over here, a sublingual ridge over here, and on this sublingual fold or ridge or elevation or whatever you call it, on this sublingual fold you have multiple glands, multiple openings. These openings you cannot see it. These are the multiple openings of the sublingual gland. So sublingual glands have multiple ducts, and the submandibular gland usually has one single prominent duct which is opening over here. So opening of the submandibular salivary gland, opening of multiple sublingual salivary gland ducts. So you have seen the under surface of the tongue, you have seen the dorsum of the tongue in the relaxed position, and you have seen the dorsum of the tongue along when the tongue is fully protruded and when the other structures are also visible through the open mouth. Now we have already said that this tongue is a muscular organ. Muscular organ means it has muscles, and muscles means they are all skeletal muscles. Now muscles of the tongue are intrinsic muscles as you can see in this picture, or extrinsic muscles as you can see over here. So some extrinsic muscles and some intrinsic muscles. If you go to the extrinsic muscles over here, again this structure is the hard palate, this is the mandible, this is the hyoid bone, this is the styloid process, and behind the hard palate this small portion is the soft palate. So hard palate, soft palate, mandible, hyoid, styloid. Now we come to the extrinsic and intrinsic muscles of the tongue. If you look at the tongue pictures, this picture and this picture, you can make out that there are 4 extrinsic muscles and 4 intrinsic muscles on the whole. The extrinsic muscles of the tongue are genioglossus, hyoglossus, styloglossus, and the palatoglossus. And if you look at the attached part of the tongue from the mandible to the hyoid bone, you can make out that from below you have first the mylohyoid muscle which is forming the floor of the mouth, the oral diaphragm. Here you can make out the mylohyoid, here you can make out the mylohyoid. Above, deep to the mylohyoid, you can make out the geniohyoid over here. This is the geniohyoid muscle. This over here is the geniohyoid muscle. Again this over here is the geniohyoid muscle. And deep to the geniohyoid muscle, you can make out the genioglossus. So genioglossus on the mandible, genioglossus on the hyoid. Over here the bulk of the muscle in the tongue is the genioglossus. Again in this picture the genioglossus from behind the mandible, from the superior genial tubercle of the mandible to the anterior surface of the body of the hyoid, this entire bulk is mostly genioglossus. And you can make out that the genioglossus, when it contracts, it is going to drag the tip of the tongue anteriorly and downwards towards its attached root, and the genioglossus of one side, when it contracts, it pushes the tip of the tongue to the opposite side. Now apart from genioglossus, you have, this is the styloid process, you have the styloglossus, and from the hyoid you have the hyoglossus. Now this hyoglossus muscle is attached from the body of the hyoid along the greater cornu and goes into the sides of the tongue. And you can see this hyoglossus is a rhomboid or quadrilateral or a parallelogram shaped muscle, and there are multiple structures which are superficial to the hyoglossus and structures deep to the hyoglossus. So the topography of this hyoglossus muscle is very important. Superficial to the hyoglossus you have the styloglossus muscle, as you can see. Then you have the lingual nerve and its attached submandibular ganglion. Then you have the hypoglossal nerve and its vena comitans, and you have the deep part of the submandibular salivary gland and its ducts. So these are all structures superficial to the hyoglossus. Deep to the hyoglossus you have the inferior longitudinal muscle of the tongue, you have the genioglossus itself, you have the glossopharyngeal nerve and the stylopharyngeus, and you have the second part of the lingual artery. These are structures which are deep to the hyoglossus. So structures superficial to hyoglossus, structures deep to hyoglossus is important. The hyoglossus is an important topographical muscle because the hyoglossus divides the lingual artery topographically into first part, second part and third part, and the detailed study of the hyoglossus is part of the dissection of the submandibular region. Then after genioglossus and hyoglossus we come to the styloglossus. It's from the tip and anterior surface of the styloid process, and styloglossus is overlapping the hyoglossus and blending with the sides of the tongue into the genioglossus itself. And the fourth of the extrinsic muscles is the palatoglossus. So palatoglossus is coming from the soft palate, from the under surface of the palatine aponeurosis of the soft palate, and it is going to the side of the tongue, and here you have the palatoglossal arch. This fold contains the palatoglossus muscle coming from the palate above and going to the side of the tongue. So this is the palatoglossal arch. So this palatoglossal arch is coming like this. Is the soft palate, uvula of the soft palate, and this arch is coming down like this as the palatoglossal arch, and this bears the palatoglossus muscle. So you can see the palatoglossus muscle. So again to recapitulate, genioglossus, hyoglossus, styloglossus and palatoglossus. And after all these muscles you have to again go back and study the relations of the hyoglossus. Apart from these four, there is a small bit of another muscle which is called chondroglossus, which is attached to the lesser cornu and adjacent sides of the body of the hyoid bone, and it blends with the muscles of the tongue. So chondroglossus is not so important. Anyway, let us come to the intrinsic muscles of the tongue. In the intrinsic muscles of the tongue, you can make out here superior longitudinal muscles, inferior longitudinal muscles, transverse muscles and vertical muscles. So these four sets of muscles constitute the intrinsic muscles of the tongue: superior longitudinal, inferior longitudinal, vertical and transverse. Now in the midline of the tongue there is a fibrous raphe formed by the intermingling of the muscles of two sides. Now this fibrous raphe goes down from the tongue and it is actually attached to the hyoid bone, and these sets of muscles of the two sides, they are actually crisscrossing through this median fibrous raphe of the tongue. So extrinsic muscles, intrinsic muscles. Extrinsic muscles: genioglossus, hyoglossus, styloglossus, palatoglossus, and some fibers of chondroglossus. Intrinsic muscles: superior longitudinal, inferior longitudinal, vertical and transverse. All muscles of the tongue are supplied by the hypoglossal nerve except palatoglossus. Palatoglossus muscle takes the nerve supply of the soft palate, that is, it is supplied by the cranial accessory through vagus after forming of the pharyngeal plexus. So cranial accessory, vagus, pharyngeal plexus, palatoglossus. All other intrinsic and extrinsic muscles of the tongue by the hypoglossal nerve, which is the 12th cranial nerve. And again in this sagittal section of the skull you can make out the oral part of the tongue, pharyngeal part of the tongue, palatoglossal arch, palatopharyngeal arch, tonsil. You can make out the soft palate over here, and you can make out the reflection of the tongue mucous membrane of the tongue to the epiglottis, and you can make out the soft palate over here. Behind the nose you have the nasopharynx, behind the oral cavity you have the oropharynx, and behind the larynx you have the laryngopharynx. Now this uvula and these palatoglossal arches together, they are constituting what we call the oropharyngeal isthmus. So there is a small sphincteric attachment over here, sort of a functional sphincter, which we call the oropharyngeal isthmus, which is actually the junction between the oral cavity and the oropharynx, somewhere here. Now these two palatoglossal arches on the two sides, they approximate, the uvula comes down and the dorsum of the tongue is pulled up to narrow this oropharyngeal isthmus. Now of all these muscles, you can make out that stylopharyngeus is the muscle which will pull the tongue backward. Palatoglossus will pull the tongue up, genioglossus will pull the tongue downward and forward, hyoglossus will pull the tongue downwards and to the sides, and the styloglossus is the only muscle which is pulling the tongue up. So when the dorsum of the tongue is pulled up and the palatoglossal arches are approximated and uvula is brought slightly down, this entire opening, the oropharyngeal isthmus, somewhat narrows. That is why it is a form of a functional isthmus, a junction point between the oral cavity and the oropharynx.